Society webinar series part 10. First of all I wish you all in a good health during this difficult time, and thank you for still be with us up until now, the 10th part of this webinar. So today we are so fortunate to have two distinguished speakers that I hope will broaden our perspective on the most hot topic in atrial fibrillation, which is the use of NOAC. Furthermore, this opportunity will be to discuss one of the current therapies in stroke prevention in non-valvular AF. As you can see, NOAC, our new oral anticoagulant, has been known to promisingly useful in preventing stroke in AF. But the following question emerges, such as what drugs should be used for a certain patient? Are all NOAC are the same? Or how NOAC compare to other drugs? For next 1.5 hours, these two distinguished speakers will hopefully answer all these questions that most of us have in daily practice. So without no further talk, may I present you our first speaker for the tonight webinar. Our first speaker will be Professor Renato D. Lopez. He is now a professor of medicine in Division of Cardiovascular Medicine, Duke Clinical Research Institute in Duke University Medical Center. He is an active researcher and a formerly part of many NOAC drug research, so I think it will be a very interesting presentation. Professor Lopez, can you hear us?
Yes.
Okay, terrific. So the time is yours, please.
Okay. I'll just open up. Hold on. Can you see my screen?
Yes, no, not yet. Okay, yes. Okay, perfect.
Okay. So thank you very much for the opportunity to be here. And I think now the goal in the next 30 minutes or so is to discuss a little bit about some special populations, lessons learned from the NOACs in patients with AF, and trying to review and identify groups of patients where we can understand about different profiles of patients and therefore understand what NOACs might be more suitable for some patients in some clinical settings. So that's the idea. Let's see. Okay, here are my disclosures. And I always like to start with this slide showing really these four major trials, because these four major trials are really the pivotal trials that led to the approval of 4 new drugs, 2 new classes of anticoagulation therapy for atrial fibrillation. And because of them, these trials really changed the entire field of stroke prevention in atrial fibrillation. As you can see here, there are 4 drugs, 2 classes. One is a direct thrombin inhibitor, dabigatran, and then we have 3 factor Xa inhibitors, rivaroxaban, apixaban, and edoxaban. And as you can see, those are drugs that have some similarities, but they are also very different from each other, or with some difference among themselves. We can understand and appreciate that, of course, we have very short half-life of these drugs, about 8 to 12 hours. We have a very rapid onset of action, only a few hours, 1, 2, 3 hours. But there are important differences. Like we can appreciate that the renal elimination is very different. Dabigatran, for example, is 80% eliminated by the kidney, whereas apixaban is only 25, 27% eliminated by the kidney. So important differences that also one needs to take into account when deciding which drug to use. And here are the summaries of the 4 NOAC trials. And we can see that those are very large studies, 18,000 people, 14,000, 21,000 people. And all of them looking really at stroke as the primary efficacy endpoint and bleeding as the primary safety endpoint, because it's always important to look at bleeding as part of the equation. And if we look at the timelines and if we look at the historical aspect or evolution of stroke prevention in atrial fibrillation, we can see that until 10 years ago, everything we knew about atrial fibrillation and stroke prevention was coming from 2,900 patients from the early trials with warfarin. We can see those trials were done in the 80s and early 90s. And those were placebo-controlled trials that show that warfarin is very good. But now, in the last years, look what happened. We have now more than 70,000 patients included in 4 major trials. And because of these trials, we are now being able to, as I used to say, rewrite this chapter in the medicine book. In other words, we are learning so much more about atrial fibrillation, risk prediction, stroke prevention, risk scores, secondary prevention, concomitant medications, and etc. So really, really remarkable times that we have nowadays. And to show that how this is so remarkable is that when we look on the left on the earlier trials in the late 80s, early 90s, the placebo-controlled trials, we've seen that warfarin is very, very effective to prevent stroke. Actually, 64% relative risk reduction in the warfarin-treated patients. Very impressive. Very few things in medicine has this large treatment effect of 64% reduction in a major endpoint such as stroke. And now on the right, we can do even better. We can be even better than that, and we can actually reduce the risk of stroke by additional 19%. So think about it. We can be very good with warfarin, and we can do even better now nowhere. But let's look at the results separately. And again, this idea is not to compare one drug to other drug, because these drugs are not compared to each other, but it's just to put the results in perspective. So all of the trials were designed to be non-inferiority trials. Why? Because warfarin is so good. If you are as good as warfarin, you are already in very good shape. They also designed the margins to maybe be superior. And the good news that every drug was able to be as good as warfarin. So every drug was able to be as efficacious as warfarin to prevent stroke. However, 2 of them were able not only to be not inferior, but was able to be superior to warfarin. And this was the case of dabigatran, 150 milligrams twice daily, apixaban, 5 milligrams twice daily. These 2 drugs were able to be superior to warfarin in preventing stroke. So really, really good news overall from these trials. Then, of course, when we saw these results, we said, okay, that's great. These drugs are at least as good. 2 of them were even better. They're safe. What happens with intracranial hemorrhage, which is the feared complication? Well, the good news is that all of these drugs, in greater or lesser degree, were superior to warfarin in preventing or reducing intracranial hemorrhage. So really, really impressive, because now we are getting to be as good as warfarin to prevent stroke, sometimes better, but even better for intracranial hemorrhage, which is a major advantage. This is probably the most advantage of the NOACs, the most important slides that I'm going to show. The NOACs have significantly less intracranial hemorrhage, at least 50% overall. So important that when you look at mortality, we find this 11% reduction overall in reduction in all-cause mortality. Of course, some trials were able to achieve statistical significance, some others did not, but overall in the same direction of 11%, 10% reduction in all-cause mortality. And as a matter of fact, to see if this was real, we published these results that we thought was very important, which was called imputed placebo analysis. And what does that mean? Well, it's not ethical to do a placebo-controlled trial anymore. There is no way I can do a trial and not treat patients with AF. So we have to use historical data and other studies to be able to do a sophisticated analysis that is called imputed placebo. So if we have done a trial of apixaban versus placebo, what would be the impact in mortality? And that's what we did here. When we look at the final plot, we can see that actually apixaban reduced all-cause mortality by 34% versus placebo. So around one third of reduction, 34% reduction in mortality with apixaban versus placebo. So very reassuring that when we found here that apixaban versus warfarin reduced 11% mortality, well, when we do a placebo analysis, we showed 34% reduction in mortality, which strengthens the results of the Aristotle trial, really showing that 34% was really, or 11% reduction in mortality was really real in the trial. So good news for now also anticoagulants being able to reduce mortality. And finally, the other bleedings, not just intracranial hemorrhage, but how about the other bleeds? And the good news is that the other bleeds called major bleeds, the NOACs were at least as good as warfarin. They were at least as safe as warfarin. But some of them were actually better. Some of them were actually safer than warfarin. And this was the case of dabigatran, now the lower dose, 110, apixaban, and edoxaban. So now you can appreciate that these results are not the same in all trials. Some drugs are as good as warfarin to prevent stroke, some are better. Some drugs are as good as warfarin in terms of safety, some are better. And all of them are better in intracranial hemorrhage. But it's important to understand those differences because when you're choosing the NOAC to be used, you need to know the results of the trial so you can choose what drug you think is more suitable for each patient population. And we talk about stroke, we talk about bleeding. Why this is important? Well, this is important because both endpoints are critical. We cannot just cut the patient in half and just look at ischemic risk or thrombosis or just bleeding risk. We need to find what I call the sweet spot. What is the sweet spot? The sweet spot means I need to be able to find the right drug at the right dose for the right patient that can give me the greatest reduction in stroke at a minimal cost of bleeding. That's my goal. Optimizing stroke reduction and minimizing risk. That's my goal. And when we talk about bleeding, it's important to remember that there are different types of bleeds. We have the intracranial hemorrhage, the most severe types of bleeds. Then we have the most common type of bleed, which is the GI bleed. And then we have the less severe bleeds, which is called minor bleeds, like hematomas or hematuria. And we learn that all bleeds are important, regardless of the severity. But let's see what these trials showed us. So let's start with fatal bleeds. So those bleeding that patient bleed and die in 30 days. We can appreciate that the NOACs have a much lower rate of fatal bleeds. That's really, really important because you not only can bleed less with the NOACs, but when you bleed, you die less often from the bleed because the NOACs have a very short half-life. As a matter of fact, we published this paper in JACC 6 years ago, where we show that when patients bled on apixaban, for example, their mortality was 50% lower than when people bled on warfarin. When you bleed on apixaban, you die 50% less than when you bleed on warfarin. And that's very important because the short half-life really is responsible for better outcomes following bleeding events. The other important piece that we learned is that during many years, we thought that aspirin was very safe and aspirin was very efficacious for atrial fibrillation. And that's the classic curves that we see in many studies. The CHADS or CHADS-VASc score goes up, the risk of stroke goes up, the risk of bleeding also goes up, and patients are more likely to use antiplatelet agents because they think that they are effective and because people are afraid of warfarin and afraid of anticoagulation. So that is the classic curves that we've seen many times in a lot of studies. However, there is a very important study. It's called the Averroes. And the Averroes trial basically compare apixaban versus aspirin, a head-to-head comparison in patients who were considered not eligible or not suitable for warfarin. And what is that trial did? Well, we compare apixaban versus aspirin in patients who could not take warfarin, and guess what? Apixaban was much better than aspirin in preventing stroke. 54% reduction in stroke with apixaban compared to aspirin. Well, this is not very surprising because every anticoagulant should be better than aspirin. Everyone. We know that aspirin is not very effective for stroke prevention. So that means that every anticoagulant should be better. So this was reassuring to see a new drug like apixaban being better than aspirin. But the most striking finding was this. The rates of bleeds were similar between apixaban and aspirin. And numerically, again, not statistically significant, but numerically lower rates of intracranial hemorrhage with apixaban versus aspirin, 11 versus 13. Again, small numbers, but very reassuring that you can use a NOAC as apixaban and you can be as safe as aspirin, but much more efficacious. So you keep the safety, but you are much more efficacious by reducing stroke by 54%. And that is why also when we look at the rates of discontinuation of apixaban in the study, apixaban was actually better tolerated than aspirin. So apixaban, people are more likely to continue apixaban and not stop apixaban and stop aspirin. And why is that? Probably because of the side effects of aspirin that were even more common than apixaban. So really important finding demonstrating that apixaban was better tolerated than aspirin, as safe as and much more efficacious than aspirin. So there is no reason, therefore, to use aspirin anymore in stroke prevention, in atrial fibrillation. And that's why the 2016 guidelines and now the 2020 guidelines agreed that antiplatelet or aspirin monotherapy is not recommended for stroke prevention in atrial fibrillation. It's a class 3 recommendation. So basically, we should not use aspirin anymore for stroke prevention. And then finally, when we talk about the GI bleeds, then the story is a little bit different. The GI bleed is the only downside of the NOACs compared to warfarin. In general, the NOACs as a class, they increase GI bleeding compared to warfarin. They have higher rates of GI bleeding compared to warfarin. Why? Well, the reason for that is because the NOACs, they are metabolized to the GI tract, whereas warfarin is metabolized to the liver. However, we found one difference here. When you look at dabigatran, 150 milligrams, more GI bleeding than warfarin. When you look at rivaroxaban, more GI bleeding than warfarin. When you look at edoxaban, more GI bleeding than warfarin. However, when we look at apixaban, we did not find more GI bleeding. As a matter of fact, we found numerically, not statistically, but numerically 11% less GI bleeding with apixaban compared to warfarin. So very important difference between these agents. And the look what the 2016 guideline says that the European guideline says that in patients at high risk for GI bleeding, we should avoid dabigatran 150 milligrams, rivaroxaban 20 milligrams, or edoxaban 60 milligrams. What do I mean by avoid? Is that we should prefer something else other than dabigatran 150, rivaroxaban 20, or edoxaban 60. Why? Because of these results that I just showed. Those drugs at those doses had more GI bleeding. So basically what the guideline is saying is that in patients at high risk for GI bleeding, we should use warfarin or apixaban to prevent stroke. Or actually, you could use dabigatran 110 milligrams in places where this is available. It's not the case in the United States. We don't have that option. But 110 milligrams of dabigatran is an option as well. So some general comments about bleeding. Well, first, all NOACs, they increase risk of bleeding compared to placebo. So that's important to keep in mind. There is no free lunch. Every anticoagulant that works also is going to increase bleeding risk. Rivaroxaban and the higher doses, dabigatran 150 or edoxaban 60 milligrams, had higher GI bleeding rates compared to apixaban did not have that. And for comparison with aspirin, apixaban was really the only drug tested versus aspirin and has shown to be as safe as in the overall study, but much more efficacious with a 55% reduction in stroke. So very important finding as well. Okay, so now when we move to the other really important population is that these drugs, they have some level of renal excretion. Some of them have very small number or very low rates of renal elimination, like apixaban, and some others have a higher rate of renal excretion, like dabigatran. And it's important to understand that we need to adjust the doses according to your local label. So your local label has to be followed for adjustment of the doses. Let's look at dabigatran and renal function. So we know that dabigatran is 80% eliminated by the kidney. So 80%. So that means that as renal function goes down, there is more drug circulating, and therefore the exposure to the drug is higher. That's why we see, if you look at the right bottom corner, as the renal function goes down, when it gets close to 50 mLs per minute of creatinine clearance, we can see that we start seeing higher rates of bleeding, numerically higher rates of bleeding with dabigatran compared to warfarin. Why? Well, because we know that the drug is 80% eliminated by the kidney. So that's why we see that. When you look at age, for example, we also see this trend that as people get older, the safety of dabigatran seems to diminish. Because of course, when you get older, you get worse renal function, and uh, we start seeing numerically higher rates of bleeding with. Importantly, when you talk about intracranial hemorrhage, this is not the case. For intracranial hemorrhage, dabigatran is safe and better than warfarin, irrespective of age. So we saw that for major bleed overall, as age goes up, the safety of dabigatran seems to go down. But that's not the case for intracranial hemorrhage. When you look at rivaroxaban, we did not find any significant interaction. So basically, rivaroxaban works the same way in patients with and without renal impairment. Consistent results. And when we look at apixaban in the Aristotle trial, we found basically the opposite that the RELY trial. We can see here on the right that as the renal function goes down, the safety of apixaban becomes even greater. Why? Well, for two reasons. One, because warfarin is a very bad drug. It's a terrible drug for renal impairment patients. But second, because apixaban is only 27% eliminated by the kidney. So when you look, apixaban is safer than warfarin across the spectrum of renal function. But as the renal function goes down, the safety goes up. So really a very safe drug, particularly for the renal impaired patients. We also show that in the elderly, just following the renal results, apixaban is a very efficacious and very safe drug in the elderly. We can see that that's very consistent results for all kinds of bleeds in the elderly, and even for patients than 80 years of age. So we also look at apixaban in patients above 80 and below 80, and the results are very consistent. Very safe drug to be used in the elderly patients above 80, as we can see here. No signal of any differential treatment effect of apixaban according to age. If anything, it seems that patients seem to be even safer if they are elderly with apixaban. And finally, with edoxaban, we found that in normal renal function, edoxaban seems to be worse than warfarin. But as the renal function goes down, then edoxaban seems to work better than warfarin. So also an interesting drug for patients with renal impairment, as we can see here. And when we look at safety, very consistent safety as well in normal renal function and impaired renal function. So edoxaban also with some good, favorable results in patients with renal impairment. And finally, the monitoring of these patients. How should we monitor these patients? Well, remember that those drugs, they were dose adjusted at the beginning of the trial. For most trials, the Aristotle, the Rocket, the RELY trial. Only the ENGAGE trial actually adjusted those during the course of the trial. But the practical question is, how often should we measure or monitor renal function for these patients? And a nice rule of thumb is that you can divide the creatinine clearance by 10. And that's the number of months that you should monitor it. For example, for somebody that has a 60 of creatinine clearance, just look at renal function every 6 months. For somebody that is 30, just look at them. Just look at the uh, just look at the monitor, or just monitor the patients every 3 months. So again, just try to monitor these patients roughly around the number of months defined by creatinine clearance divided by 10, and will be very safe. The 2016 guidelines and now the 2020 just published 2 weeks ago clearly recommend NOACs over warfarin as a class 1A. So there is no question that today, in 2020, NOACs are a preferred option over warfarin based on everything I just said and based on the amazing results that the NOACs compare to warfarin. Remember, this is my trade-off. I have to reduce choke as much as I can, and I have to prevent bleeding or minimize bleeding as much as I can. That's my goal. Finding the sweet spot, reducing stroke as much as possible, minimizing bleeding as much as possible. And we have ways to do that. For intracranial hemorrhage today, there are 3 things that we can do to really minimize the risk of intracranial hemorrhage. First, use a NOAC instead of warfarin. Second, stop concomitant aspirin. Patients chronically with AF, they don't need antiplatelet agents. So stop aspirin, because aspirin is an important predictor of intracranial hemorrhage. And third, control blood pressure. If you control blood pressure well, and you stop aspirin, and you give a NOAC, the rate of intracranial hemorrhage is never going to be 0, but it's going to be very, very, very low. So when we talk about sweet spots, this is a good example of sweet spot. So on the left, I have the magnitude of stroke reduction with different drugs. And on the right, I have the magnitude of bleeding reduction. You can see that for stroke reduction, the greatest reduction in stroke is with dabigatran, 150 milligrams. However, when I look at bleeding on the right, I'm in the bottom with dabigatran. If you look at bleeding alone, edoxaban 30 milligrams is the greatest reduction in bleeding. But when I look on the left, is not very efficacious. As a matter of fact, increase the stroke by 41%. So it doesn't help to be very good for stroke and bad for bleeding, or very good for bleeding and bad for stroke. The secret here is to be good for stroke and good for bleeding at the same time. If you do that at the same time, then we found the sweet spot. Then we found the best treatment to our patients. Well, should we believe in everything I just said? Well, I think we should, because first, the number of patients is 20 times more than the warfarin trials. So large number of patients. Second, we have very robust subgroups results. And more importantly, all these trials and all this data that I presented, they were from a contemporary practice. The warfarin trials were done, more than 30 years ago, and medicine was very different at that time than it is today. So all of the NOACs have the same advantage of not being warfarin. So that's their first main advantage. They are not warfarin. Therefore, you don't need to monitor them routinely. There are no major food or drug interactions. We have a very rapid onset of action and a very short half-life, which is really good to manage bleeding. And in general, they are very well tolerated. So some of my summary recommendations, I think that any NOAC is preferred over a no NOAC. Apixaban really has this really unique profile, is the only NOAC that has been shown to be superior to warfarin for stroke and bleeding. does not increase GI bleeding compared to warfarin, and is as safe as aspirin. So a really unique set of findings and profile. The ROCKET trial and the ENGAGE trial, they had on average higher CHA2DS2-VASc patients, but remember that apixaban and dabigatran trials also have a large number of high CHA2DS2-VASc patients as well. And with rivaroxaban and edoxaban, it's once daily. Sometimes this can be a good advantage in terms of polypharmacy and managing many drugs. But remember, the most important thing when we talk about anticoagulants is not just compliance, it's actually clinical outcomes. If you have a drug that can reduce stroke, reduce bleeding, and reduce death, that is the outcome that we want to get. That's that we should use. So to conclude, ladies and gentlemen, I think we are in a new era of anticoagulation for atrial fibrillation, and I think we need to embrace this era. Patients using traditional therapies such as warfarin, they continue to have a lot of events, particularly intracranial hemorrhages and bleeding events. I think now we have better options, at least 4 drugs. All of them are safe and effective and have important advantages over warfarin. The main advantage, in my view, is the reduction in intracranial hemorrhage, which is much lower with NOACs compared to warfarin. So that's a very important finding. Of course, remember that how we're going to use that is going to depend on efficacy and safety, and of course, cost. Remember, we cannot say that one drug is better than the other because they were not tested head-to-head. That's why we use the word attributes. This drug has some interesting attributes that I can make the drug maybe suitable for this patient, whereas others have different attributes that might not be so attractive for some types of patients. Remembering to balance out bleeding and efficacy, sweet spot. We need to be good for stroke and good for bleeding at the same time. Please do not use aspirin. We know that is not effective and is not safe for stroke prevention. And please do not use aspirin together with an anticoagulant other than the few initial days after a PCI. The in-hospital period, like a week or so after the PCI, is only when we really gonna need to use aspirin. Other than that, we don't need. Despite that, it might be a little bit too premature to completely eliminate warfarin from the options that we have, because warfarin still have an indication in some clinical scenarios such as antiphospholipid syndrome or even in mechanical valves as the main class of anticoagulants to be used. And I think now we know a lot about the NOACs, but we still have a long way to go to get the same experience that we have with warfarin with these agents. And that's why now I say that we are getting to the end of the beginning. It's still a beginning of a new era, but we know a lot about NOACs and we are getting to the end of this beginning. We still have a long journey to go, learning more about NOACs to be able to give the best to our patients. Thank you very much for your attention.
Thank you very much, Professor Renato. Very nice presentation, very comprehensive. If you have any questions, you can write it in Q&A column in the right of your monitor. So we step up to the next speaker, which is our member of INA HRS, Dr. Daniel Tanu Budi was currently active as an electrophysiologist consultant at an Eka Hospital BSD Tangerang and graduated from University of Indonesia Jakarta and fellow electrophysiology in Korea University, Seoul, South Korea. Okay, Dr. Daniel, time and place is yours.
Thank you, Dr. Agung. And also thank you for Professor Lopez for the very brief, very detailed content of your talk, and I think we share the same slide then. So for me, I will go as quick as I can, because I'm looking forward also for the discussion with you, Professor Lopez. And also greeting to my colleagues. Selamat malam semua, INARS, Indonesian Heart Rhythm Society. Thank you for this opportunity. And also thanks to Pfizer who sponsored the event and also provide most of my slide then. Let me share the talk. Okay, this one. Can you see the slide, Dr. Agung?
Yes. Yes. Oh, yes.
Okay.
Okay.
Yes. So this is my theme. So I think this is some like complementary to the talk of Professor Lopez, because I think we have already the detailed information about the NOAC. But now regarding the challenge and the many obstacles in Indonesia, and also I will give you a couple of cases regarding the stroke patient in Indonesia, and also regarding the use of NOAC. So this is my outline. I will go with first with the AF in increasing ages and the stroke prevalence in Indonesia. So as you see, I think we have already see a lot of, this slide show us that the incidence of AF is common and anticipated to increase. Nowadays, in daily clinical practice of us, also we face very frequent arrhythmia called AF compared to other. AF is very common and then increase in number during the next decade. And also, these slides show us that in Indonesia, we have increasing number of stroke, at least in the 5 years. So compare with the 2013, in many provinces in Indonesia, there's averaging data that the number of stroke is increased. So it's similar pattern in the right side. AF it is increased, and then in the left side the stroke prevalence is increased. That's why I feel that I need to show you this some number, but let us see that most of the stroke is ischemic stroke. So this is also show us that the stroke ischemic is very related with the AF. Say that 5 in a stroke ischemic is due to the AF, embolic stroke, and the result is very devastating for the patient, because I will show you the couple of cases that when the patient experience the ischemic stroke from AF, embolic stroke, then the area that the brain is damaged supposed to be or will be very huge. This is slides from my friend in some data from the National Hospital in Indonesia. So problem is in Indonesia, majority of stroke patients arrive at hospital about 6 hours from the onset. So the reason for delay admission is because of unaware of having stroke and transportation problem. We all know that in Jakarta, especially, the traffic is very bad, and this is also our obstacle to handle the patient with stroke. So it is very important to us, the clinician, to have some insight and some update about how we can prevent the stroke before it happens. Because when it happens, the result is not so good in our condition, our environment, and also the knowledge of our patient as well. So let me show you one case. This is actually my case in my hospital, female, 78 years old, just come August last month due to the loss of consciousness. You see, it is since 24 hours. So they spend almost a day in their home to take care their mother by themselves, and not aware this is the loss of consciousness is due to stroke. More interestingly, this lady have also history of ischemic stroke 2 years ago. So this is the the sequence, yeah, the second attack of the stroke, and the patient also have a long-standing atrial fibrillation since 2017 on rivaroxaban 20 milligrams, candesatan, and so on. But the problem is that she stopped the medication since April. This is due to pandemic. The compliance also become decreased because of patient afraid to come to hospital and also forget to continue the medication. This is the patient CHA2DS2-VASc score and Hus-Bled score. CHA2DS2-VASc score is very high, so means that when she stop the medication, especially the stroke prevention medication, then it will be happen. Okay, and then this is her ECG show us atrial fibrillation, and you see, because of the embolic stroke of the atrial fibrillation, almost half of brain of our brain, one of hemisphere is damaged due to the embolic. So the problem in this case is compliance issue. So we can discuss how to fix it, because nowadays during the pandemic as well, we face maybe the same problem, how to encourage patient to continue the medication or come to the office or come with the telemedicine, something else. And the problem also, the question also, when is the safest time to start again NOAC after there's a very huge embolic ischemic damage in the brain. So we start Riva 15 milligrams after 1 week. After I also give advice. The neurologist give us advice to start again the NOAC after 1 week, because he also think about the risk of another ischemic stroke. So the balance between them. Unfortunately, a week after the patient discharged in NOAC, before 1 week, patient come again with the loss of consciousness, but also short of breath, and then asystole, and then the patient passed away in the hospital emergency. So I think there's some insight from professor, maybe also from the audience, how to start again the NOAC. Second things, NOAC in Indonesia, the same slide, Prof. So we already have 4 modality of NOAC. We have dabigatran, rivaroxaban, apixaban, and edoxaban as well. So the problem is to choose one after the others, yeah. And how we also promote or give the information to other physician to have a NOAC or warfarin into the several case of to prevent the stroke in AF patient. Now I just showed you that the stroke is divided into the infarct, TIA, and hemorrhage. The interesting in apixaban is, and also I think in all NOAC is not non-inferior compared to warfarin to reduce the ischemic stroke, but a bit superior to reduce the intracranial hemorrhage. So this is very, this is very interesting because also in some paper, Asian patient is more prone to have a intracranial hemorrhage, especially in the elder or advanced age. Okay, this is, I think, just want to show you again. This is the same slide with Professor Lopez, that the NOAC compared to warfarin and NOAC is very efficacious for the preventing stroke, ischemic especially. And for the aging, also, as we see in the slide, that age after or above 65 is the benefit to give apixaban compared to warfarin is very good. And also, as you see, again, that intracranial bleeding is reduced in patient with apixaban. So I think we now, as Professor Lopez mentioned, that we now in the remarkable era to give our patient the best solution to prevent the stroke, or also to maintain the quality of life of our patient. That's why we need to update our knowledge and our information regarding the stroke prevention in AF. I think the rest of the slide I will go quickly because you already heard it from Professor Lopez regarding the safety and efficacy of apixaban in high-risk population, especially in the advanced age and the chronic kidney disease. So again, AF prevalence is increasing age. So if you see now the patient getting older, our patient, and also the risk to get AF during their lifetime is increasing as well. So means that increasing age, then the risk of AF or having an AF is increased as well. So in the patient with the advanced age like more than 80, apixaban is better than warfarin. See, a lot of information regarding the safety. So I think also this is our opportunity to also inform the patient that this drug is not a harm as they think. Because if a patient, we tell the patient that we will give the blood thinner, then usually patient will ask how about the risk of bleeding. So we are going to give the patient the medication with the evidence base. So we need to have some information in order to to give information as well to the patient, to take to give the patient more comply to the drug that we give. This is Averroes, yeah. Also remarkable finding that compared to aspirin, apixaban is better in reducing stroke ischemic, but same with the aspirin. So we also in Indonesia, Prof. Lopez, we also used to give the aspirin, baby aspirin. The patient also already know that yes, this is a very safe drug. But from this study, we know that give NOAC, especially apixaban, also safe for our patient. And this is also show us that increasing age, remarkably, that apixaban will also give a safety result with a better result. And interesting of note is 80% of intracranial hemorrhage patients with warfarin had pre-INR before the patient come with the intracranial hemorrhage, less than 3. So yeah, I also have one patient, but unfortunately, I don't have time to collect the data. That one patient have also the intracranial hemorrhage with patient maintenance with warfarin, but amazingly, the INR at that time is not above 3, so below 3. That's also show us that the warfarin is not as safe as we think, even though we already treat the patient in the or among the therapeutic area INR 2 or 3. This is my second case, the female, elder age, 79 years old, July, 2 months ago, come with unconscious in the bed 30 minutes. So this is better because, because the house of the patient is very close to the hospital, and they're aware of the some. So in Indonesia is very variable and level of knowledge of the patient and family. One case they're not aware, one case aware. So this is our duty as a clinician to give our patient as much as possible the information regarding the disease, regarding the risk, and regarding the medication that we gave to the patient. So patient also have a long-standing atrial fibrillation since 2 years ago, but she maintained with the rivaroxaban 10 milligram. Interesting, because maybe the physician afraid of bleeding problem. So give the lowest dose, the possible lowest dose for this patient. Even though the CHA2DS2-VASc score is 4, but Hus blood is only 1. So they maintain the Riva 10 milligram. The result is with atrial fibrillation, and then July, 2 months ago, patient come with embolic stroke as well. With MRI, as we see, almost also half of the brain is damaged. That's why we know that this is the cause of this problem is because of the embolic. So our issue is the use of NOAC in the elderly, in the advanced age. And what about the off-label dose of NOAC? So regarding the apixaban, is there any study? Usually, Japanese usually infers to, to have some data around their country regarding the lowest dose as possible. So I read standard registry, the use of apixaban 2.5 and 5 milligrams in Japan. So maybe we can discuss about this as well. The rest of the slide, I think the same with Professor Lopez, so I will not go through with this. CKD patient is one of the high-risk patient with the increasing number of the CKD, also, decreasing renal function means that the risk of stroke also increase. So we need to protect the patient with the decreasing renal function. And Aristotle studies show us that across the spectrum of the GFR, the apixaban is better than warfarin. Also, actually, four of our modality of NOAC also have some good performance compared to the warfarin in CKD patient. So, ladies and gentlemen, as a conclusion, as we see that in line with the worldwide, AF and stroke also increase in Indonesia. And in our case, in our cases fatality also driven by ignorance, compliance of the patient. So this is our duty to inform. Before we can inform the patient, then we have to also the knowledge and the update data about the or regarding the NOAC and the stroke prevention. And our case show that NOAC useful across the high-risk patient, advanced age, or CKD. Thank you very much for attention. Back to Dr. Agung.
Thank you very much, Dr. Daniel Tanubudi. Very interesting presentation and very interesting case, which your case trigger some question around the question and answer. So we have a few minutes for a question and answer. The first question is to address to Dr. Renato, to Professor Renato. How do you manage anticoagulant in patients with end-stage renal disease but had history of recurrent embolic stroke? So the patient had high chest fast and also high Hus blood score. So what is your opinion, Professor?
Well, renal impairment is a very broad spectrum of disease. We have to define what renal impairment are we talking about. I feel very comfortable using NOACs until patients have 25 mL per minute of renal impairment, because that's what the trials, or at least our STARTLE trial did. So I think, as I showed, that there are some agents that might be more suitable for renal impairment patients, like apixaban or even edoxaban. If you have less than 30 mL per minute, then apixaban is the only trial that actually went up to 25. And below that, then we have very limited data. In the United States, apixaban can be used for dialysis. So in the United States, we use apixaban for dialysis because it is approved by the FDA. There is a label by the FDA to use in dialysis. We don't have a lot of data. We tried to do a trial called RENO-AF, less apixaban versus warfarin on dialysis. But unfortunately, the trial was not completed. The trial was stopped earlier. And therefore, it became only an exploratory trial and not a definitive trial. So, in other words, I think we have to be very careful in the very extreme of renal impairment, like dialysis patients. I think that's the situation that we don't know yet very well how. What I do know is that I personally don't like warfarin on dialysis patients. I think warfarin is not safe, and I don't think we have any good data that show that warfarin is effective to prevent stroke in patients on dialysis. So that's why this is a patient population that you have to see case by case. That some people might do, especially if you have coronary disease, is to use dual antiplatelet therapy in these cases for the coronary disease. If the patient had coronary disease, think carefully about anticoagulating these patients with warfarin because the data is terrible. And an option that people have considered is also left atrial appendage occlusion for these patients, although without a lot of good data yet, but as an alternative that one could consider, and maybe in the future would be more used for this population. So those are some of the options, but it really has to be individualized case by case because we don't have a lot of good data.
Okay, thank you, Professor Renato. So Dr. Daniel, do you have any experience of using NOAC in dialysis patients?
No, I never use NOAC in dialysis. So because the study, I think Prof also have no data in the dialysis patient, but I heard that Professor Lopez have experience to give the apixaban in the dialysis patient. Looking forward for the data. I mean, maybe we can also share how about that, because it's very common in our daily practice also to see our patient in hemodialysis regular patient. So usually I give warfarin. and control and try to control the INR.
Yeah, it's very challenging, right, to use warfarin in the dialysis patients, even more so than in dialysis. The experience in the United States, based on some of the observational data, again, very careful, is that apixaban does very well on dialysis. And my personal experience has been also good, but these are personal experience or even observational data from the US large databases of insurance, so far showing no signal of any problem with apixaban in dialysis. But it would be really nice to have some randomized data to confirm that.
Yes. Thank you, bro. Can I ask Dr. Agung?
Yes. Okay, please, Dr. Daniel.
So I also curious about your Augustus trial, Professor Lopez, because also we also face some problem to decide it how to use the NOAC and then also the antiplatelet for patient with AF and PCI. So I also already read your Augustus trial. Then to confirm that, now on, then we can use apixaban with the clopidogrel, right? In the patient with AF and also PCI or CAD patient.
Yeah. So I think what we learned is that for patients who get a PCI and has AFib, the double therapy is going to be the standard. So we're going to use aspirin only for the in-hospital period, only for a few days, 6-7 days. And the time of discharge, we're going to use a NOAC, like apixaban, which is what we did in the Augustus trial, plus clopidogrel as the standard. So we're going to use only these two agents for 12 months. And after 12 months, we can stop the clopidogrel and continue only with the NOAC, in this case, apixaban. If you have a PCI that is very difficult PCI, very complex, difficult lesions, bifurcation lesions, calcification, multiple stents, it's reasonable to keep aspirin for 30 days. It's reasonable to keep aspirin for 30 days, plus clopidogrel, plus apixaban, and then you can stop the aspirin at 30 days and continue only with clopidogrel and apixaban. I think we learned that from the Augustus subgroup analysis that we presented and published in Circulation in the last few months.
Yes. Thank you, Prof. This is good insight for us. And is there also the strategy also already adopted in the guideline or will be adopted in the guideline as well?
Sorry, for what?
For the strategy to give the NOAC and also clopidogrel for AF and PCI patient also already adopt in the guideline, American or European?
Finally, the European guideline that was just published 2 weeks ago already has exactly that recommendation. So the European guidelines basically follow what we did in Augustus, which is basically 1 week for aspirin, double therapy for most cases. Aspirin can be given to 1 month in case of a high risk for ischemic events. You can keep for 1 month, and after 12 months, only anticoagulant. So all of this now is incorporated in the recent 2020 European guidelines.
Oh, thank you, bro. Regarding the antidote for the apixaban, is there any update or progress around that area?
Yes, we have the andexanet, which is an antidote for factor Xa inhibitors, particularly approved in the US by the FDA for apixaban and rivaroxaban. So we already have an antidote approved in the United States. It's called andexanet alpha, and it seems to be very effective. It starts working within minutes, very effective. But to me, the general principles of antidotes is that for the NOACs, most of the times we don't need, because the best antidote for the NOACs is time. You just wait a little bit and the effect is gone.
Thank you, Prof. Dr. Agung, silakan.
Okay, thank you, Dr. Daniel. Okay, Professor, next questions. There is a questions from our audience here. She's a doctor and he has a AF patient who has already a NOAC with a good compliance, but the patient is still on experience an ischemic stroke. So how do you think? What is the cause, or how we can prevent this, or how can if we can change the drug or something we can do?
Well, first of all, these drugs are not magic. Nothing is magic in medicine. Nothing is 100%. So it's not because people are taking NOACs that they are not going to have strokes. They are going to have strokes. This happened in the trials. In the trials, a lot of people had strokes on a NOAC. That's part of the game. You have to minimize, you have to reduce, but it doesn't mean that it's zero. So first of all, keep that in mind. Second, by far, the most common cause of a stroke on a NOAC is bad compliance. That is by far the most common. So make sure that patients are taking the drug. If they are taking the drug, then also keep in mind that not all strokes are cardioembolic strokes. Not all strokes are related to atrial fibrillation. So it is possible that somebody has a problem with the carotid disease and have a stroke that has nothing to do with the NOAC, and therefore the NOAC is not going to be protective of that necessarily. So that's all things to keep in mind. But once you evaluate everything and you saw the patient is compliant, there was a cardioembolic stroke, that patient does not have any other cause for the stroke, and you really feel that this was like an event on a NOAC, you have two options. You can continue the NOAC if you think that the patient is using the most appropriate NOAC, or what we can do without data, but we sometimes do, is change classes. So if the patient was taking a factor 10A inhibitor, you can switch to a direct thrombin inhibitor, change class to see if the patients do better. So if the patient, for example, have a ischemic stroke and using rivaroxaban, you could switch to dabigatran, for example, because you're changing classes and you're making sure that patients are experiencing a different class, maybe even a more potent class, which is the factor 2A inhibitor, a more potent drug for ischemic stroke. And as long as the bleeding risk allows that to be done. So again, you can always switch classes or switch drugs if you wish, because we don't know every details about NOACs yet. Remember that we learn about clopidogrel resistant only 10, 12, 15 years later.
Yeah.
So we don't know everything about NOACs. So it makes sense to switch to another NOAC, particularly what I do, I switch to another class. But again, without any good data to do so.
Yeah. How about changing the doses?
Sorry, what's that?
How about to change the doses? Maybe up the dose or something.
Well, yeah. So if the patient is using a low dose NOAC, like 110 dabigatran, or basically that's the drug that is approved in terms of the lower dose, or a off-label low dose, then absolutely the first option is to come back to the right dose. Okay, we know that underdosing is a problem. So a lot of times people are receiving 2.5 of apixaban, and they don't have the criteria to use the adjusted dose. They only have, for example, age, or they only have body weight, and they don't have the second criteria to adjust the dose. So please do use the approved doses. If we use underdose, if we use low doses, we are likely going to see more strokes. We learned that from the trials. So if somebody using 110 of dabigatran and have a stroke, absolutely, I would increase to 150 or switch to a factor 10A inhibitor. Correct, because you have to use the right dose. Absolutely.
Okay, thank you, Professor. Dr. Daniel, maybe you want to add a comment about this?
Not many, I think, because the case also show us the second case that my patient lady, almost 80 years old, with the Riva 10 milligrams, which is off-label in ROCKET-IF, show us in 2 years they didn't protect well, and then happening to have a embolic stroke. So agree that we have to use on-label dose of the NOAC. Thank you.
Yeah. So the key is the use the proper dose for the NOAC. Okay, next questions. There's question to Professor Lopez. What do you prefer for bleeding risk? What do you prefer to use for bleeding risk score for patients need NOAC? And could we use it for guidance which NOAC we can choose? Thank you.
So none of the risk scores for bleeding are very good for atrial fibrillation. And I think the HAS-BLED is a reasonable score to use for, first, to think about the modifiable risk factors. So I don't use any score to decide to treat or not treat, period. No scores, because no bleeding scores. Because remember, goal in atrial fibrillation is to prevent strokes, is not to prevent bleeding. So I use no scores to decide to treat or not for bleeding. However, I do use scores to assess what my bleeding risk is and to remind me of the modifiable risk factors that I need to control before treating someone. So for example, oh, the patient is on aspirin, let me stop aspirin. Oh, the patient has no good control good blood pressure control. Let's control better the blood pressure. Oh, the patient is taking anti-inflammatory drugs. Let's stop those drugs. So those are things that made me think about when I apply a HAS-BLED score, and I changed that. I changed those factors before starting the anticoagulation therapy. But remember, we should never use a score alone to contraindicate or to withhold anticoagulation therapy. That is not indicated, and we don't need to do that.
Okay, thank you, Professor. Maybe this is the last questions. What do you think of AF patients with an PAD event and the vascular surgery has already given cilostazol as anticoagulant? Should we add more NOAC or what NOAC we can choose for this patient?
Yeah, we don't have very good data on that. We have the Voyager trial now, but those are patients without AF. And we learned that when you don't have AF, you can add low dose rivaroxaban as an option, just like the COMPASS regimen. But once you have AF, then the best data that we have is probably extrapolate from the Augustus trial, which will be probably use an anticoagulant with some antiplatelet therapy for at least 6 months, maybe just one antiplatelet like clopidogrel, and go with that. But I don't think you need to keep cilostazol on board, because that's basically only have shown to improve symptoms, but not really outcomes in this patient population. So again, we don't have good data for this patient population. What I've seen people using is extrapolating from Augustus to the PAD population, and use maybe the novel anticoagulant like apixaban with one antiplatelet for at least 6 months, and then after that really only go with anticoagulant for the AFib.
Okay. Thank you, Professor. So, Professor, this is one more question. When the safest time to use NOAC with person who have AF history and have stroke hemorrhagic attack?
Sorry, what's that?
What is the safest time to use NOAC with person who have atrial fibrillation and have stroke hemorrhagic attack?
So when you have a stroke that is hemorrhagic, you have to really make sure that you assess the size of the intracranial hemorrhage and the comorbidities, like how was the blood pressure, was patient on warfarin, what is the location of the intracranial hemorrhage, is it lobar, is it deep? So there are several aspects to be looked at, and is it a purely hemorrhagic stroke or it was a ischemic stroke with hemorrhagic conversion? Those are two different situations. So, but in general, I would say that you're going to start anything between 4 to 8 weeks. Of course, it's going to depend on a lot of factors like blood pressure, warfarin background, location of the hemorrhage, size of the hemorrhage. If you have a very large hemorrhagic versus a small hemorrhagic conversions, those are very different situations. But what I can tell you is that before, until 3-4 years ago, we were very reluctant to restart anticoagulants in patients with intracranial hemorrhage. And now we are being more and more aggressive in doing so. And there are even studies ongoing with amyloid vascular disease, which we know are very likely to cause bleeds. And even in that scenario, we are now getting more and more aggressive and restarting anticoagulants. But of course, it has to be evaluated. It has to be a team, a neurologist and a cardiologist. And usually we will start between 4, 6, and 8 weeks after the intracranial hemorrhage.
Okay. Thank you, Professor Renato. Okay, due to the time constraints, we have to end this very interesting webinar. Thank you, Professor Renato, for being here, broaden our knowledge about NOAC. Thank you, Dr. Dajjal Tandubudi, for the presentation. Thank you very much. Professor Renato, maybe we can see each other next time. Thank you very much.
Sure. Thank you very much. Thanks. Bye.
Okay.
Guys.
Bye-bye. Oke, kembali ke Dr. Farah.
Baik, terima kasih kepada Dr. Agung, Dr. Daniel, and also thank you so much for Professor Renato Lopez for your time and sharing a lot of knowledge tonight. Untuk webinar selanjutnya, seperti biasa, kita lanjutkan di Jumat malam untuk membahas case yang pastinya menarik dari mulai EKG hingga IgM-nya, from outpatient to EP lab. Dan akan ada materi tentang penggunaan device pada heart failure. Nah, untuk link di hari Jumat itu, kebetulan kita akan memakai Zoom, dan nanti linknya akan kita share ke masing-masing email peserta yang sudah terregistrasi, dan juga nanti akan kita share di bio sosmed INAHRS. Maka dari itu, jangan lupa untuk selalu ikutin medsos kita dan juga Facebook kita. Sekian webinar malam ini. Terima kasih kami ucapkan untuk seluruh peserta yang telah berpartisipasi pada malam hari ini. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Selamat malam.
Selamat malam.